My name is Angela Hayes. I'm the Nurse Fellow and Project Lead at the Centre for Sustainable Healthcare, and one of the co-leads for the network. We meet monthly, the last Thursday of every month at 12:30, where we invite speakers to our online events. They're free to join, and we're very keen to have as many members join us as possible. We are recording the events so they're able to be viewed if you're not able to attend in person. We've got the chat facility, so please do use that for any questions, but we can pick these up after we've heard from our speaker. So without further ado, I would like to introduce our speaker today, who is Pip Noble. Pip, we met through the Green Nursing Challenge that we ran this year in 2025, and Pip today is a midwife. She's the lead midwife for the East of England Maternal Medicine Network based at Norfolk and Norwich Maternal Medicine Centre. In her role, she supports women with complex medical conditions during pregnancy, acting as a bridge between the various services and areas of expertise required to optimise both pregnancy outcomes and ongoing health within the context of their medical condition. Pip's work focuses on ensuring timely and equitable access to specialist care for women and birthing partners across the region, facilitating collaboration between multidisciplinary teams to deliver high-quality patient-centred care. So I'm going to hand over to you now, Pip, if that's okay.
Yeah, that's brilliant. Thank you so much. Can you hear me okay?
I can hear you perfectly, yes.
And I'm going to check, did my slide move along?
Yes, it did.
Yeah, brilliant. Okay, that's always my first worry. It's like, is it going to work? Yeah, thank you so much, Angela, for letting me come along today and speak to you about our Green Nursing Challenge that we participated in. This was facilitated between myself as the maternity representation, and Heather Simpson was the IBD lead nurse specialist as well, who worked collaboratively with me on this project. But it's really important to note as well that it was the MDT involvement and team of both the maternity and the inflammatory bowel disease specialist team, so that, you know, came together to make this possible, which I'll go through a bit more as we describe the challenge and the implementation that we put forward. So the first thing that we really identified, and I think a lot of this came through really seeing and experiencing firsthand the care journeys that many women were facing during pregnancy. And we know pregnancy itself is a complex journey. It's the most exciting time often for people, but it's also can be fraught with, you know, anxiety sometimes and lots of decisions and factors to consider. And particularly when you place that in the context of having a pre-existing medical condition as well, that adds that additional burden of what pregnancy means for both your medical condition and how that might change based on pregnancy, but also how that condition itself can impact and might influence pregnancy and outcomes as well. So there can be a lot to navigate for women, just even in the context of having a condition in the first place. And I think really we recognise that in itself can be quite a psychological burden within pregnancy. There's lots of complex health decisions sometimes to be made, lots of information to process, and lots of, you know, ways of navigating evidence and decisions around medications as well. So that side of it, plus often there's the practical sense as well of pregnancy. You come up and you see a community midwife, you see your hospital-based maternity care, but on top of that, when you have a medical condition, you're also juggling multiple medical appointments as well. And the combination of all of that in your daily life, as often women are, you know, busy perhaps with work, with families, they're juggling their normal day-to-day life within this as well. And that can lead to lots of different stress points, potentially financial stresses, time pressures, and the impact as well of both of those things on their, you know, availability to both attend appointments, but also to, you know, have the time to attend outside of things like work as well. And I think from this, you can sometimes see patterns of women really struggling to navigate and juggle all these balls in the air of their complex journey. They sometimes are prone to having problems with making all those appointments that might cause missed opportunities or missed appointments. And we know that those in themselves are missed chances to help support optimum disease control and health optimization. And I think in the context of this, if you additionally layer in the fact that when some women might have pre-existing additional challenge based on their socioeconomic situation, and you have other existing health disparities, that can make it even more challenging to balance all of these needs. You know, if women are facing financial hardship and are struggling to get to their appointment and have to, you know, have 3 bus journeys to get there in the first place, that in itself is going to make it really challenging for them to engage in multiple appointments across multiple specialities. So I think, to summarise that sense, we really we're trying to look at how we sustainably bring together a model that works for the woman and for her care, but also works for all of the needs that need to come together to promote a healthy pregnancy and a healthy mum and baby. And I really always like the sort of the graphic and the vision of the woman is there with her growing pregnancy and this life that she's starting, and within this she's got all these complex puzzle pieces of her own life that she's trying to bring together to wrap around those needs that she has for her pregnancy. So I think with this, and particularly around inflammatory bowel disease, we really recognised the need to try and collaborate and bring together both specialities within one singular appointment. We saw quite a vast number of women now coming through with inflammatory bowel disease, and we know that actually a lot of women of childbearing age are in that sort of common time window where they might get diagnosed with inflammatory bowel disease as well. So with this, we were seeing quite an increase in numbers, but more worryingly, we were also seeing quite an increase in women having active disease and flares, particularly when entering pregnancy as well. So I think it really was an opportunity to both try and improve that health accessibility for inflammatory bowel disease within that really key window of pregnancy as well. And we know pregnancy is often one of those times where women are most engaged and most motivated to engage with health services as well. So the vision was for an integrated multidisciplinary care model in a single clinic. So this would bring it together the inflammatory bowel disease specialists, such as specialist nurses, the gastroenterologist, alongside her maternity care. So this may be the obstetrician and also the midwife as well. And this was care that's delivered then through one simple coordinated service for their obstetric appointments, bringing together all those puzzle pieces so that they're not juggling multiple different appointments across specialities and the risk that more siloed care can bring. And we felt that this was particularly valuable for those with complex needs and additional social disadvantages and vulnerabilities as well. So the idea being that in a general normal schedule of care for somebody that might need consultant-led care in maternity, they often come up with their obstetric ultrasound scans and then see an obstetric doctor following that who would plan their medical care, their obstetric care through that pregnancy. By bringing together the inflammatory bowel disease team into the same appointment, those women with inflammatory bowel disease could see both those specialists that can support with the ongoing planning for their infusions and their outpatient care from the nursing speciality. The gastroenterologist can be there to help advise about optimum treatments to try and promote healthy control of their disease, and obviously their obstetric support as well within the context of their pregnancy and the health of the growth of the baby. So in terms of the design, we identified that obviously the initial key stakeholders to bring together for this were bringing together those specialities I've already mentioned. And I think particularly between myself, Heather, and our obstetrician, we really saw that need, that gap in service, that often women were experiencing quite long delays to get any gastroenterologist access. So there was quite an overburden of the gastroenterology service in general, for even outside of pregnancy. So many women were already quite delayed in their routine follow-up for their ongoing health and care, which perhaps reflects that sort of pattern we were seeing as well of a lot of women coming into pregnancy in sort of a poorer disease state potentially, or inactive flare. So engaging those specialities, and particularly the gastroenterologist, into the clinic was part of that design. We also ensured that we had support from the administrative team in terms of helping to support those changes in appointments and the redesigning of the clinical templates as well. And where we approached this was very much from a cost neutral redesign. So instead of setting up new clinics, new pathways, and additional time on both parts of the clinical teams, this was blended into the already existing consultant appointments that would happen for a woman with inflammatory bowel disease and pregnancy. So generally they would come at their booking appointment at 12 weeks, have their first scan. They'd be seen potentially at 20 weeks with their fetal anomaly scan. And then from 28 weeks onwards, generally 4 weekly after that. So as opposed to setting up a new pathway, we blended in the gastroenterology teams into that pre-existing clinic. So there was no need to redesign new staff, no infrastructure that was required in terms of new premises. It was about the sort of reallocation and the time of the specialist teams coming together. And I think it was really important that we highlighted to the teams from gastroenterology that benefits it had in terms of improving their access and their workload as well. With their already stretched gastroenterology clinic lists, this freed up the space where these women should have been seen for other operational needs, as they were allowed, enabled to be accessed by being seen in a combined clinic instead. So although it hasn't directly reduced the workload of the gastroenterologist and initially might have seemed to increase it by them coming across into a different clinic, it does consolidate that care into a really clear single structured monthly clinic, rather than being approached ad hoc week by week for new women that might book a pregnancy and then need advice and guidance from a gastroenterologist due to perhaps a flare or a complication in pregnancy. So it created a more identified space for that routine and robust follow-up for these women. And this really helped to align to best practice standards for the care of pregnant women with complex conditions such as inflammatory bowel disease. And certainly from a maternal medicine perspective and the work of the National Maternal Medicine Networks, this coordinated MDT-led care is really the gold standard care that should be aspired for. So I think really the template reflected a sustainable collaborative approach that was prioritising the quality of patient care, but also was benefiting the service as well. I think the overall benefits for the women will come on to in a little bit as well, but obviously by integrating all the teams together for all the reasons discussed at the beginning of the presentation, that social impact and sustainability for her to continue to engage and keep up with those appointments is far improved. I think in terms of longer term evaluation, it would obviously be good to track the neonatal and maternal outcomes, and we'll touch on a few of those a bit later on that we were initially able to scope out, and obviously the sustainability of the teams working within those care models as well. So in terms of outcome measures, we looked at a few different directions to try and see how this might improve care. We were looking at the patient feedback in terms of the patient journey and how this collaboration of services helps improve a multitude of things. Hopefully their experience, their access to MDT care, their access to coordinated advice and guidance that was consistent as well. Sometimes we would get feedback prior to this that women might get conflicting information from different clinicians and different specialities, and sometimes that's born out of that sort of silo working again, of not understanding each other's provisions and each other's specialities. We're actually bringing together the specialities in the same clinic. The teams are able to learn from each other, understand the implications of both sides of the speciality, the inflammatory bowel disease on the pregnancy and the pregnancy on the inflammatory bowel disease. So we wanted to understand how women themselves experience that, and the obviously the impact and improvement hopefully on things such as time and travel, accessibility. We looked also and wanted to understand from an environmental factor the associated emission factors of doing the separate pathways with the appointments both in the gastroenterology service and the obstetric, and what that looks like from an emission factor of combining into one single pathway of appointments. And we were also really keen to understand from staff feedback as well how they experienced giving care within the clinics as well. So our main parameters that we looked at clinically were the number and length of the number of patient travels and number of appointments per speciality. We looked at the number and length of neonatal admissions as well to try and understand that slightly more longer term outcome for baby by hopefully optimizing the health of the pregnancy and the mum. Were we improving the outcomes as well that we see for baby? And we know that women with inflammatory bowel disease with poor disease control and active flare are at increased risk of potential complications in pregnancy, and potentially a higher rate of preterm birth and needing to deliver earlier due to their disease activity. So we were really keen to understand any changes there. The number of pregnancy flare episodes and the number of those that were severe enough that led to hospital admission, the number of escalated medications that were needed due to a flare, such as steroids or indeed even IV steroids or biologics, and the same in terms of the number of day case therapies that were required to be escalated to as well. So in terms of understanding what we found, we obviously put our metrics in to measure and then implemented the clinic redesign. After we'd engaged the stakeholders, we looked at our caseload of all known women with inflammatory bowel disease and obviously looked then at how we could reallocate their appointments into this new pathway as opposed to their pre-existing ones. And that was done through the help of our administrative team. And then we commenced our first joint clinic thereafter. So in terms of understanding the social sustainability impact, we found that the new pathway did reduce the number of appointments as they were now collaboratively combined, which minimised the financial and travel burden. We simplified the care journey, and women did feedback that felt more supportive. There was more continuity of experience by them seeing the same obstetrician, gastroenterologist and nursing team each month. And we felt that this enhanced the equity of access as well by having a better coordination of care. In terms of our metrics, our total journeys reduced from 112 to 76, which was a saving of 3,090 miles. And that really helped to save about, I think it came out at £115 per patient that was saved to them in terms of that cost of travel as well. So that financial benefit was there as well to the women and families, which hopefully in turn helps to improve access and equity for those where that may be a barrier. So overall, it was felt that this model integrated the accessibility and the consistency for women within their care journey, and that overall patient experience as well was improved. And I think very much the package of care helped to try and identify and give that space for women to feel that they had a really unique journey that was recognised specifically within that clinic pathway for them, and helps improve the connection of care between the teams, which also helps that future pregnancy health as well. So in terms of the impact environmentally, we did see a reduction in the carbon footprint with the combined clinic. As you can see here, we had a 74% reduction. The biggest area that we found for reduction of emissions was in the medication use. So within our pre and then post cohort of the clinic, we identified that there was a reduction in the need for escalating medications due to active flares. Whilst we did recognise that sometimes the heterogeneity of the cohort of women that we had in the different cohorts can be impacted by the severity of their disease that pre-exists already, we did recognise that there was fewer women that needed intensive therapy such as IV steroids and hospital admission in the after group following the combined clinic, where there was quicker and more timely access to expert advice, quick treatment for and identification of a flare, and therefore more lower level medication that could be used first of all, as opposed to needing to escalate to further IV therapies for tractable disease. So we had an improvement in that. We also saw a reduction in admissions through the patient travel, a reduction in hospital admission beds and day cases, and also a reduction through a fewer number of babies requiring the admission to the neonatal unit post-delivery as well. So that was a real positive thing that we saw in terms of seeing an environmental reduction. Comparing the before and after, the biggest change, as I say, was also the hospital admissions in terms of the largest gain in an individual area was seen in the fact that the hospital admissions went pre was 2 and reduced to 0 following. So from that sense, we saw an overall 100% reduction in hospital admissions in the post-clinic introduction. So in terms of financial and clinical sustainability, we felt that there was obviously a perceived savings due to the reduction and the improvement of preventative care. So before integration, the 2 separate pathways of care in the clinic appointments equated to 95,567. And after the integration of services and the streamlining of the combined clinic, this was reduced to 77,623. So we saw a financial improvement there as well. And whilst these weren't active pounds there and then in the pocket as such, it was through the the reduction of the need of those clinic spaces on the gastroenterology lists by the women moving across. That obviously reduces that financial strain and burden within that service by freeing up that capacity. In terms of savings as well, there was large financial gains in terms of the saving of inpatient bed stays. And again, whilst those beds will still exist and still be funded for in terms of the staffing and the costing ongoing with a different patient in them, there was a reduction, obviously a perceived reduction in the amount of women that are needing to access that bed. Medication saving was also noted in terms of the reduced need for additional therapies such as IV biologics and IV steroids. And as mentioned before, by the reduction in the number of babies that needed the neonatal unit due to preterm delivery, there was also a perceived cost reduction there as well. And £7,560 was obviously saved through the reduction of duplicated appointments where they would be seen across both pathways as well. So very much the cost saving was around an optimization and reallocation of clinical time rather than a direct cost saving. As mentioned before, it's obviously difficult to have direct and firm findings based to the heterogeneity of the pre and post clinic cohorts may influence some of the outcomes. So some factors such as inpatient bed admission and neonatal admission could be influenced by the state of disease that the woman comes into pregnancy in and how severe and how active her inflammatory bowel disease is. But I think very much the team really felt that long-term outlook of the clinic and the sustainability model of it is the more women we see through a pregnancy, optimised support, and then hopefully help deliver that preconception counselling ready for the next pregnancy, we're optimising those future pregnancies into better health as well. And I think certainly the earlier access within the clinic and the more timely response that came from the MDT approach there and then in the room to start an escalation of treatment or therapy, we felt very much reduced the number that might need to escalate into further complex management during a pregnancy. So I think in terms of staff feedback, we found positive feedback from staff and very much by being in a room with your MDT colleagues. I think they really noted the improvement in confidence of caring for women with inflammatory bowel disease in pregnancy. And there was noted to be more interdisciplinary learning, greater exposure to that sort of collaborative understanding of each other's fields and specialities. And they felt that there was more structure to the clinical care planning as well by being aware and in the room real time with each other. So very much that improvement was seen there, but additionally the benefits identified were the continuity of care and how that made for a smoother, more consistent follow-up. And I think the staff felt more pride and satisfaction in the support that was being given for pregnant women as well, and seeing that benefit by seeing the women come back month after month as well. So the challenges, as mentioned already, we would love to study this over a longer period of time to really understand the ongoing cohorts. So some of due to the sort of time window of the Green Challenge. Obviously, that sometimes is limited to less than the journey of the pregnancy of some of those women that would be within the clinic. So we'd like to look more longer term to understand how and what outcomes longer term might be being improved. And I think understanding a bit more about what specific improvements we may be able to link to the combined clinic model and that impact for those longer term outcomes as well. We would love to see preconception care coming through the clinic more as well. We do offer a preconception service here as a maternal medicine network, but not specifically within the IBD clinic at present. But we would like to look at whether capacity can expand to allow women to come through into that model of care before pregnancy in terms of pregnancy planning. And that would allow even greater space for optimization of their health prior to entering pregnancy and that continuity of care as well. So in conclusion, we hope that we've demonstrated that the model supports a sustainable high-value care approach that aligns with the NHS goals of better patient outcomes, reduced variation in care, and an efficient way of delivering service delivery that we hope is sustainable for the future. It reduces unnecessary clinical interventions, promotes timely access to specialist care, and hopefully helps to improve those patient outcomes, both short-term and long-term. And the clinic model contributes to a much more cost-effective, but above all else, patient-centred healthcare system, that is sustainable in its approach for both the women and the service. And that is the presentation. Thank you.
Thank you very much, Pip. It's an absolutely wonderful project. You should be really proud. Yeah, can I hand over, see if anybody has any questions?
Thank you.
Yeah, no, I mean, it was just really amazing to see all the work that you've been doing. Can I just double check? I think you said this, but like, can you clarify again, how long was it that this project was going on for?
So the project itself started in, when did the challenge start, Angela? I forget. Was it
January?
January. Yeah. So I think the clinic itself started in, I think we did our first one in March, and then the window of the challenge ran up to August, was it? I think.
Yes.
Yeah, to right. August. So obviously for some women that came through within the new integrated pathway in the new combined clinic, they might not have yet completed their pregnancy. So obviously that gave us challenges in not having some outcome measures for those women who yet hadn't delivered. But we were able to look at their journey up until that point and see what escalation of care had been required. So we looked at our pre-clinic introduction, we looked at a set number cohort of those women, and then we looked at the same number that were within obviously the combined clinic pathway as well, most of which had delivered, but there was just a couple of women that obviously some of these women transferred onto this pathway obviously midway through their pregnancy as we established the service and set it up and moved them across into the combined model.
Yeah, I mean, that's so interesting because like just if someone wanted to kind of replicate what you've kind of done in your service, because I mean your infographics, all the data, it looks so incredible, and I just wonder how would it be for someone who wants to do this. I mean, it seems quite complex to calculate all the emissions, to calculate the financial impact. How did you go about that?
And it was quite a long one to try and map. And I think we obviously mapped it, first of all, using the Mira board of trying to look at all these different things that hopefully tried to show that the care that you were doing was what were you trying to improve? So we were trying to improve the number of women that were getting delays due to sort of having flare symptoms, delays then accessing care and the specialist to deal with those symptoms and then start treatment. So I think that's where we focused on looking at how many women had flares, what gestation were they that they had a flare, what treatment did they have, and how many flares did they have in a pregnancy. And we also looked at then mapping, okay, how many times did they see what speciality and how early did they manage to get to see a gastroenterologist pre and post. So with the clinic introduction, they obviously saw a gastroenterologist as early as 12 weeks at that first appointment. But obviously, if they were in the old model, some women weren't managing to get access to anyone at all in pregnancy, only if they had an acute issue or a problem. So there was as such was like a deep audit before to understand all those metrics and what the care looked like for those women pre. And then obviously it's about then looking, okay, for once the clinic has been introduced, what does this now look like for the women in that cohort, and how timely are their responses to those different factors, as they say, like the number of times they have a flare, the number of times that they need to access escalated treatment as well. Does that answer the question? Possibly not.
Yeah, no, I think it was really good. Yeah, no, thank you.
Hello.
Thank you so much for the presentation, Pip. That was super, super interesting. I had two questions, I guess. One following on to the previous question. How long do you think you will be measuring outcomes and following up in terms of evaluation until you think you have like some kind of final outcomes where you can tell us, oh, this is the outcomes of this project across the pregnancies that we've been looking at? Is that a year maybe, or do you have a plan for that?
So I think we'd definitely like to evaluate it at a year following clinic introduction, and within that we hope that we will get obviously a certain amount of women that have journeyed through the pathway from beginning to end. So I think it would be interesting to review it at a year altogether anyway, and then we'd like to get a certain amount of women that we've definitely been able to measure it from start to finish as well. But I think it's something that we'd quite like to continually audit on a yearly basis as well, and see and really try and understand that cohort of women as well, and how often women we are seeing coming through with inflammatory bowel disease in pregnancy, and what obviously their care and their outcomes looks like long term as well. So I think we'd like to continue it as a regular rolling audit and review.
Okay. Amazing. Yeah, it would be interesting then to have you back again in a year or so to get the final results.
Yeah.
And the other question I had, it's such a great project, and it's not just applicable to inflammatory bowel disease, but it could be applicable to so many more chronic diseases that impact pregnancy at the same time. Do you have any others in mind where this model of care could be also maybe fitting, and that where it could be like taken and used as a template?
Absolutely that, yeah. So I think what this really did is sparked that need. Like there's so many other specialities that we could see that this would really relate to. And I think as a model of care, it's a really good model of care that suits so many different specialities. So I think the other one that we were particularly keen to look at next is epilepsy. Because that combined approach with the specialist care nurses and the neurologist is again another example of that. They're juggling lots of different appointments. Often that MDT need for bringing that care together is really acute, and you want to make timely connections between those professionals there and then if there's any acute changes in their care. So I think we absolutely want to look at replicating it across different specialities, and we do have other speciality combined clinics such as cardiology as well that already exist. But I think the slight difference with this that we really found is sort of also bringing in the additional support services within there, such as the nursing teams as well, really sort of helps give that holistic view for the women across all of the people that look after her with that particular medical condition alongside her pregnancy as well.
Brilliant, thank you so much.
So Pip, I've just got, Anna, you've asked one of the questions that I was going to ask, but have you, so you've talked about kind of plans for development in your organisation, but has anybody kind of approached you from outside on the strength of the competition, or, you know, and looking to implement similar kind of projects in there?
Yeah, so I think we're really well positioned by being part of the Maternal Medicine Network, because we already work quite collectively across the east of England to share ideas and share obviously what good practice and a good model looks like. So I think from that point of view, where we connect with our other sort of spoke hospitals in the east of England, and they're looking at what their own maternal medicine services look like in their hospital, we're able to share this as an example of that combined model approach for different specialities. And again, some sites already have combined clinics in place, but perhaps haven't already seen it through that sustainability lens of how that improves and impacts both, the type of care that they're giving, but also from a sustainability modelling why it's so important as well. So we're able to then share the project in that light, and they can sort of see it from that benefit too. And I think that hopefully helps grow the need to develop those speciality clinics even more. And I think IBD is not one that has been seen so much locally, and there's quite a growing interest about actually the benefit, as we are seeing more and more women, I think, coming through, of developing this as a speciality clinic as well.